As I'm listening to the talks, I think you guys will be surprised to find out that there's a lot of parallels between what's happening in the United States with cervical carcinoma and what you see in Africa, but on a completely different order of magnitude, of course. So we practice right on the border of Mexico, and so we are one of the busiest cervical cancer hubs in all of the US, save a big referral center like MD Anderson. We see, I don't know, John, what would you say, several cervical cancer patients a week, and they're all locally, regionally advanced. They usually present with hemorrhage, and the reason for that is they're almost predominantly undocumented Mexican illegals. So they sneak across into the United States. They're not covered by US health care. And the state of California, I must say, treats them very, very well, because once they have a diagnosis of breast cancer or cervical cancer, they're then covered by the state of California. So they just have to get the diagnosis, which of course is not easy. They're not getting pap smears, they're not getting early biopsies, they're not getting colposcopies. They present to the emergency room either with acute renal failure or more often with hemorrhage. They get a biopsy, and then all of the private hospitals say, you have cervical cancer, go to UCSD. So then they show up at UCSD. So we treat a lot of local regionally advanced. A lot of them are economically disadvantaged. They don't speak English. It's hard for them to access kind of the social system. So that struck me as kind of a parallel in the kind of patients that I see. The other thing that struck me is you talk about the traditional healers here in Africa. So in America, we call that naturopathy. And so we see a lot in Southern California of people that get their diagnosis of cervical cancer, and then they go to these naturopathic physicians, and they go to Mexico and they get apricot enemas and coffee enemas and parsley diets, and I'm not making these up. These are all things that I'm thinking that my patients had with either, and I only treat breast and gynecologic cancers because of my background in gynecologic oncology. And so often they'll return with tumors that are much more aggressive, and I've had any number, too many to even think about, that have then died of metastatic disease because they didn't get treatment that is very readily available for them. They just chose not to do it. So although there's a parallel with your traditional healers, these are people that actually have the option for curative therapy and choose not to do it. So we have the socially, economically disadvantaged group that don't really get curative care but should. And then we have the uber wealthy. And I am struck by how the uber wealthy often get worse care than people that are right in the middle, because it's the first thing that their money cannot fix. And so they doctor shop, and they go from doctor to doctor and center to center. They go internationally to Germany. They get these stem cell things, and they also end up presenting with cancers that are far later than they should. And I'm going to give you an example, and I hate to do it, but Steve Jobs is an example of a person who was uber wealthy, who had a very curative cancer, who thought with his money and his knowledge and how brilliant he was, he could somehow subvert standard of care, and he ended up dying of metastatic disease of what should have been a curable cancer. So we see that in the United States that you probably don't see here. The other thing that I find really tragic, and this I've had to deal with as the president of the American Brachytherapy Society, is we know that brachytherapy is an essential part of the curative treatment of cervical carcinoma, but brachytherapy is declining in its use in the United States, even though patients have access to it. Now, sometimes they have to travel far, not as far as here. Sometimes it's expensive and they don't have money, not as much as here, but a lot of radiation oncologists don't provide this service. And they don't provide the service because we're not doing a good enough job of educating our residents, because radiation oncologists feel a little bit hesitant to do invasive procedures because it's time consuming and the patients are sick and we don't get reimbursed as well. So for an example, to be certified in the United States by the American College of Surgeons, your cancer center has to collect certain data. So you would think of all the curative cervical cancer patients in the United States, how many of them get brachytherapy? And the national number is 72%, which is just heartbreaking. So all of these people have access to brachytherapy. Most of them can be covered by insurance now, thanks to the Ambulatory Care Act. But only about 75% of them get brachytherapy. And in the state of California, where I live, it's only 60%. So we also have people that have access but are choosing not to do it, which I'm just struck here they don't have access and they want it. There we have access and people don't do it. And I blame some of it on radiation oncology, and we're writing a big paper with the Society of Gynecologic Oncologists telling the gynecologic oncologists, I think the gynecologic oncologists don't know that their radiation oncologists aren't giving brachytherapy or aren't giving curative care. And so instead of going to the radiation oncologists who know that they should be doing the right thing, we're going to now go to the gynecologic oncologists so that they can make sure that they're radiation oncologists. So I was struck by all those parallels. So I'm just going to go a little bit over what we'll do. And again, the cervical cancer incidence to mortality, you can see worldwide it's only a 50-50 cure rate. In the US, we have about a 70% cure rate, but you can see, in Africa, it's about a 30% cure rate. Cervical brachytherapy, so LDR point A. In the United States, even though we don't need to treat this way, and there's reasons not to treat this way, the majority of people still treat to point A, and I'll show you kind of how we're pushing people, at least in the United States and in Northern Europe, and whoever has imaging, to kind of switch. And of course, the definition we all know, bladder dose, rectal dose, and I'm also going to point out why the bladder dose has never been representative of bladder toxicity. So image brachytherapy, this is a series of papers that came out, really led by the Europeans in the Embrace, that shows that you contour, so on CT or MRI, and at UCSD we've been big proponents of you don't need an MRI, you can do it on a CT scan. You basically contour all gross residual disease and the whole cervix, and that's your target. And this is just a cartoon showing that. This is just showing that we want to know the dose to the most irradiated part of the bladder, the most irradiated part of the rectum, and the most irradiated part of the sigmoid. And I want to point out here, this is the perfect example, and this is what it looks like. So here, here's the old bladder point, and it's almost always the tandem that gives you the bladder dose. And I see this over and over again, and that's why the rectal point is actually pretty good, and that's why it correlates with rectal toxicity. But the reason bladder toxicity doesn't correlate with that dose is because it's almost always lower than the highest dose to the bladder. And these are just the targets that have been published by Jack Estro, and we use the EQD2 formula, which somebody's already pointed out. And so what we do at UCSD is they get conscious sedation. I look at what you guys, the number of patients you have to treat, and John and I have done this for a long, long time, and we're pretty fast, and it takes about 2 hours, which I think you probably couldn't do here. And that includes starting an IV and giving them medicine, which probably takes, 30 minutes. The procedure itself is very quick, 10-15 minutes. Then we contour, which is probably 10-15 minutes, and the physicist can get ready in about 30. So we probably, if we didn't have to do the whole IV thing, or we could do that in a different room, it would probably take an hour to an hour and a half. You have to replan with every fraction. We tend to give 5 or 4 fractions. We do a lot of needles, so if we can't cover the disease because we've got advanced patients, we do a lot of SIADs. And this just shows on an MRI, you can see, do I have a pointer up here? I don't know. Okay. So see this hyperintense area, that's gross residual disease, and of course the tandem inside the uterus. And so the MRI allows us to look at disease response. But having done this now for almost a decade, I think, almost all of our patients, even the really advanced patients, will shrink so that the tumor's just surrounding the tandem. And so you really can use a CT. And those that don't shrink at all. They come in and you've done 5 weeks of external beam and they still have, wall-to-wall disease. We still give them a SIAD interstitial treatment, but those are patients that we know are probably going to do poorly, and they either fail distantly or they fail intra-abdominally. Okay. This just shows that tumor regression happens mainly during the external. There's little regression during the brachytherapy. And the worst tumor type, and this is what I've just found in my clinical practice, when you look and you have that moth-eaten appearance of the uterus, those patients do really poorly. I can't prove it enough to switch over to palliative care, but almost all of them fail, not distantly actually, intra-abdominally. And that's just looking again at CT versus MRI. And the clinical outcomes are better. So if you did standard point A dosing and then you switched it over to image guided, the dose to 90% of the tumor ranged from 50% to 160%. So even though point A is a great thing and it's cured a lot of people for a long time, when we can transition, if you have imaging, it'll help the patient. And again, it just shows that the local control is very good. And the doses to the normal tissues are better, and so what we're trying to do is increase the cure rate while decreasing the side effect profile. And this is just the European retro embrace, again showing a low side effect profile. And I'm not going to go through all of these. A 70% reduction in pelvic recurrence compared to the old historical controls of point A. And I'll show you why that is. So again, the normal tissues. So this is one of my patients just showing on CT. I mean, it's really easy to see the vagina and the cervix. And that's just the cervical tumor filling the vagina. So you really can see what you need to see on CT. We actually did this, gosh, 2010. He's now a gynecologic oncologist that has returned and joined, and this was one of our first papers before we had residents. And we compared CT to MRI and showed that CT is really fine. It's great to have an MRI. It's like the Ferrari, but you don't need it. So Ferrari to a good Honda to a Fiat, right, if you just have 2D imaging. So an MRI, again, you do a T2 MRI, you don't even give them IV contrast. It's really fast. You take 3, you take an oblique, you take an axial. If you can't, there's lots of people in the United States that don't do an MRI, and again, that shouldn't be a barrier to doing image guidance if you have a CT. And this was just a study that we did looking at CT versus MRI, and it shows that actually the delineation is pretty good. The only thing is with advanced disease, the CT tends to show a wider, because you can't differentiate the vessels on CT and you can on MRI, you tend to encompass the vessels and think it's part of your high-risk CTV or your cervix or your tumor, and so you tend to go wider. And again, I don't want to belabor this too much. We've got so much to talk about, but especially on the panel. And this shows, see how much the red is the CT imaging and the blue is the MRI, and see how it's wider on the CT. But the superior edge, the inferior edge, and the anterior and posterior, of course, which is the bladder and the rectum, are the same. And again, this is a patient that had a great response, and it's virtually the same for an early cancer. Corpus dose, we've also noticed that in my transition to image-guided brachytherapy, I was a little bit afraid to change the isodose lines until I had a patient that came back with a sigmoid ulcer, and I went back and looked at her imaging, and the sigmoid was sitting right on the fundus of the uterus, and we were giving it a dose, and so I gave her a sigmoid ulcer even though there's no tumor at the fundus. So now there's papers that show that you can actually decrease that dose superiorly to avoid the fundus. And again, there's lots of places, and this is what we do at UCSD, where we only get an MRI on one fraction or not at all, and overestimates. And then this just shows our local control at 2 years, which is about 72%, with a local recurrence of 4%, pelvic recurrence of 5%, distant failure of 20%. So obviously the systemic therapy is where we really need to work as well. And this just shows a patient. So it's a movie, but I don't have the movie working, and I just want to point out, this is a fusion of the CT and the MRI. This is a small uterus. This is the 100% isodose line, and you can see we're going right through the bladder, even though this is the cervix. And there's a sagittal image as well that shows that the tandem is where you give the most dose to the bladder, and with image guidance we just pull that back. So this is after we pull it back. This was an elderly woman with a cervical cancer, just to spare her some bladder toxicity. We have a spreadsheet that shows us our doses, and this just shows that you still have to look at it. This looks really strange if you do cervical brachytherapy, and the reason it is, we had a new physicist that was there that hadn't done brachytherapy because all of ours were out, and they loaded the tandem all the way into the vagina. So we would have gotten a big fistula right here. The patient would have probably gotten a rectovaginal fistula if we continued to do that, and so when you look at it, you think, oh, that looks really strange. It took me about a second to think, oh, should look like that. And so you still have to look because our spreadsheet doesn't give us all the numbers. And then this is just this, you can get a link to from the American Brachytherapy Society, where you can do cumulative doses to make sure that the dose to your high-risk CTV is high enough and the dose to your normal tissues is low enough. And I think that's it. I was going to talk about the new endometrial cancer, but I will not. Whoops. I think that's it. Thanks.